Good evening. Today I will be presenting on a paper about treating anxiety in children with high functioning autism spectrum disorder, otherwise referred to as high functioning autism. There are high levels of comorbid anxiety experienced by children with high functioning autism, and modified cognitive behavioural therapy, or CBT, interventions have been found to be effective in treating anxiety for this population. However, this study claims that the need for modified CBT programs with children with high functioning autism has been assumed without sufficient empirical evidence. It is asserted that unmodified programs for anxiety disorders may be efficacious, but that this is not being studied. The authors argue that more freely available and prolific unmodified CBT programs may allow children with high functioning autism to more easily access care. Specifically, they state that computer-based CBT programs may help to reduce barriers to accessing treatment and may be particularly appropriate due to the common interest in technology among children with high functioning autism and the flexibility they can provide to families. The authors introduced Brave Online, an unmodified computer-based CBT program for the treatment of anxiety in children, and detailed studies on the efficacy of this program with children and adolescents without high-functioning autism. Immediately, it is evident that there are some issues with the premise of the paper. Firstly, there is a lack of evidence to support some of the key arguments made. The authors did not provide any references when claiming the lack of evidence on the effectiveness of unmodified CBT programs and the need for modified programs being assumed. This is despite there being studies which have investigated the use of unmodified CBT for anxiety with children with high functioning autism and found them to be effective. There was also no references provided to back up the claims regarding the greater accessibility of unmodified CBT programs or on specific barriers to accessing treatment experienced by children with high functioning autism. There are also indicators of potential author bias. The Brave Online program was developed by the authors, and the authors self-referenced their previous evaluation studies of the program. So the authors hypothesised that children in the intervention condition will demonstrate a range of improvements compared to the waitlist control group. These include greater anxiety remission rates, greater reduction in the number of anxiety diagnoses, anxiety severity and symptoms, and internalising behaviours, as well as greater improvements in overall levels of functioning. A range of measures were used which appear to appropriately measure the relevant constructs and are reported to have good psychometric properties. Following referral, screening, and a diagnostic interview, included participants were randomly allocated to the intervention or waitlist control. Pre- and post-assessments were completed for all participants, and 3-month follow-up was completed for the intervention group. The intervention, a therapist-assisted computer-based CBT program, included 10 child and 6 parent sessions, and data analysis included chi-square, ANOVA and MONOVA to test for group differences pre- and post-intervention, and linear mixed model analysis was used to assess changes over time in outcome variables. 42 children participated in the study, with 21 each in the intervention and waitlist control groups. Children were aged 8 to 12, with the majority being male and from middle to high income families. The most common anxiety diagnosis was social anxiety disorder and generalized anxiety disorder being the second most common, with participants averaging 3.36 anxiety diagnoses. There were no significant pre-treatment differences in demographic or outcome variables found between the groups. In terms of hypothesis testing, there were no statistically significant differences between the intervention and waitlist control at post-assessment on those free of their primary diagnosis or those free of all diagnoses. However, these results are considered at length in the discussion, therefore I've outlined them here. The intervention group did, however, show a significantly greater reduction in number of anxiety diagnoses, clinical severity of anxiety, anxiety symptoms, and internalising behaviours, as well as improvements in overall functioning from pre to post-treatment compared to the waitlist control. This can be seen by the differences in mean scores between the groups, as well as the results of the linear mixed model analysis showing significant pre to post slope effects for all included measures. In the discussion, the authors reiterate the main results, indicating partial support for the hypothesis. While there was no significant difference between groups on loss of primary diagnosis, there were significant findings for other outcome measures as shown in the results. These significant findings on positive reductions in anxiety and improvements in overall levels of functioning, however, are only briefly covered in the discussion, with very minimal consideration of their clinical implications. Much greater attention is given to the non-significant results regarding loss of primary diagnosis. Comparisons are made with a previous study by the authors, which found a significantly greater loss of primary diagnosis in a similarly aged neurotypical sample. However, no comparisons were made with results on modified CBT programs to understand how these outcomes compared with remission rates for children with high-functioning autism using modified CBT programs. The authors propose that the lower levels of program compliance in the current study could help to explain these non-significant results. Yet this is later contradicted in limitations when the authors state that compliance was similar with other studies with neurotypical children. The authors go further to suggest the self-help nature of the program may have impacted compliance given the difficulties faced by families with children with high-functioning autism, and they state that these results indicate the possible need for further support. However, they did not address whether this suggests that adapted programs and possibly in-person treatments are actually necessary for this population. The authors conclude that the study provides preliminary evidence that unmodified standardised CBT programs can produce statistically significant reductions in anxiety for children with high-functioning autism. Based on the results provided, I believe that this conclusion is supported by the data. However, the authors also conclude that these results suggest promise in increasing the availability of cost-effective and easily accessible CBT interventions to successfully treat anxiety in children with high-functioning autism. However, the study did not include any hypothesis regarding improved accessibility. This was not included in the study's measures or design, and therefore there were no results to support such a conclusion. Indeed, the results regarding issues with program completion might be evidence in contrary to this assertion. While several important limitations of the study are acknowledged in the limitation sections, the authors did not talk about the strengths of the study. I noticed strengths in the methods, particularly in the measures used, the comprehensive screening process, and the strong data analysis methods chosen. The authors talked about the small sample size being a limitation. However, they did not address the lack of socioeconomic and cultural diversity in the sample affecting the representativeness of the results. The authors also acknowledge issues with attrition and levels of non-completion among participants being a limitation. However, they go on to say that completion rates are similar to other studies of Brave Online and that non-completion of internet programs has been an issue in all studies of Brave Online. There was no further discussion about this suggesting limitations in the intervention itself. Finally, the crucial limitation of the absence of face-to-face CBT comparison group was discussed, making it impossible to determine if the difference in effects is from the treatment being unmodified or it being online. The authors mentioned several research implications that arise from their study. They identified that for future studies, an increased sample size would enable the investigation of predictors, mediators, and moderators of the treatment outcome to better understand which children would benefit most from the intervention. I believe this is critical, in particular, to better understand why families found challenges completing the intervention and how this may impact the benefit of such unmodified programs. The authors also acknowledged the need to compare the intervention with other modified and unmodified online and in-clinic treatment. This is crucial if we are to understand the relative effectiveness of this program compared to others. Disappointingly, there was very minimal discussion by the authors on the clinical implications of the study. The results suggest that intervention may be effective as an anxiety treatment. However, without comparisons with modified treatments, it cannot be said that such an unmodified treatment holds any benefits over available modified treatments. Further, the issues with attrition and non-compliance have significant potential implications regarding the appropriateness of online treatments for this subgroup, which needs further examination. Taking these results into account and given the lack of evidence to support claims about unmodified interventions increasing accessibility, I do not think this study sufficiently supports its claims regarding the promise of Brave Online for treating anxiety in children with high-functioning autism.